Please feel free to ask any questions. You guys had questions. Here's an opportunity so that you can clarify anything you would like to. All right, the theme of this Q&A was on cardiac drugs. So page 4, a 42, you got it up there? Thank you. A 42-year-old woman who presents with intermittent palpitations. Event monitor revealed short runs of SVT, 10 to 20 beats. Blood pressure is 118/70, pulse is 78, echo unremarkable. Symptoms are bothersome, but not debilitating. Best initial agent. You have your QR codes. You can answer the questions. We've got some Jeopardy music. Thanks for joining us, Howie. All right. Okay. So usually when I see patients like this, I'll ask the patient, how much is it really bothering you? Is it bothering you enough for me to put you on something? This patient said, bothersome but not debilitating. And I chose to observe. What do you guys have to say, Rich?
Yeah, I would totally agree with that. I mean, obviously, having brief episodes, and it depends how many, and it says short runs of SVT. If they were having 200 a day, 200 episodes a day, I might differ compared to, 4 a day or something like that. But in the absence of structural heart disease and a normotensive individual with palpitations that are not considered harmful, I would observe. Now, alternatively, if somebody says, I can't live my life with these, et cetera, then of the agents that you list, I think the standard of care would be a beta blocker. It doesn't necessarily have to be metoprolol. It could be any of the beta blockers. All right. The other drugs I would reserve for other...
I have a couple of questions with other drugs following.
Okay.
Dr. Wright's always ahead of the game. In fact, and that he said no structural heart disease. That's why I put echo unremarkable. So thanks, Rich. All right, question number 5, the next question. This is a 21-year-old anxious patient, palpitations during stress, heart rate spikes during presentations. And that was my heart rate when we were fellows at UC Davis and had to make a presentation. Okay. Metoprolol. Good choice, I think. What were you about to say, Richard?
Yeah, I mean, or see a psychologist, or to deal with anxiety. I mean, these are catecholamine-mediated arrhythmia, and I think, sure, metoprolol is a reasonable choice. And again, if it's maybe there's a reason to get an EKG or a monitor to prove, or just have the guy get an Apple Watch, whatever, to say, okay, what are the arrhythmia you're having when you're stressed out, right? Just to document that it's sinus. It's probably just sinus tachycardia or maybe PACs or something. I might want to confirm that. But if that's the case, it's either you talk them through it or you use a beta blocker. I would agree with that.
So one of my coworkers says he loves propranolol. He says it's like Xanax. So you were talking about seeing a psychologist. So he says it's like Xanax for the patient. So propranolol versus metoprolol?
Well, it's shorter acting. It's lipid soluble. I mean, it's one of the reasons why it's used for tremors. And shorter acting is both pro and con. Obviously, you're not going to have lingering effects. Both agents can contribute to depression. That's a downside. So if somebody has palpitations and depression, you might want to use a non-lipid soluble beta blocker like atenolol. That's the one that's been the most commonly used over the decades. because metoprolol can aggravate depression for sure and cause sleep disturbances and nightmares and various things because it does get into the brain. So the main difference between propranolol and metoprolol, in my view, would be duration of action. And hence, choose there are a dozen beta blockers to choose from. Metoprolol has sort of been the most commonly used, and partly because it has long-acting preparations. In Europe, though, metoprolol is not the number one long-acting beta blocker. They use bisoprolol over there.
I have a quick question here. If the choice D was Xanax, which one would have preferred?
So they said alternative would be an anxiolytic agent, as you're saying? Yeah.
It's a good question there. Okay. Next page question number 6. 60-year-old with borderline low blood pressure, 100 over 60 millimeters of mercury, frequent palpitations, and symptomatic. Okay.
I'm getting dizzy watching this here. It's like, I think there's not enough information to answer the question, right? I mean, because a 60-year-old with, first of all, borderline, 100 over 60 is a normal blood pressure in the world. It's just borderline low for America, so I want to point that out. You need more information because the frequent symptomatic palpitation, for all I know, is the guy's in atrial fibrillation, and that's why his rate's 100 over 60, right? So the determination as to which drug, if any, to use is going to be dependent on what are the arrhythmia. Presumptively, these are arrhythmia. Could be just sinus tachycardia. But I would first confirm what the person's arrhythmia are. Now, the good news is with, used to be we would have to do extended EKG monitoring. Now with all the home devices, people can use a Cardia device, or they can use an Apple Watch. Because if they come into me and they're having symptomatic episodes of atrial fibrillation, the answer is going to be totally different than if it's just PACs or SVT or sinus tachycardia.
My thinking behind this question was that metoprolol is very soft on blood pressure. You're going to get about a 5 millimeter reduction. If you get more than that, you may be lucky. So metoprolol is very soft on blood pressure. And if you had to use an agent, that won't lower blood pressure as much as the direct arterial vasodilator like diltiazem. So that was and digoxin.
Yeah,
you want to make a comment?
Yeah, we'll amplify that. So in the heart failure world, if this were a patient whose blood pressure is 100 over 60 because the person has an ejection fraction of 40% and their palpitations are due to atrial fibrillation, then the answer is digoxin. It turns out. Now for low EF heart failure, metoprolol in sinus rhythm is terrific. Raises ejection fraction. It's the cornerstone of therapy for dilated cardiomyopathy. It's great, except it doesn't improve outcomes in patients with AFib, even with low EF. And there have been randomized trials, digoxin versus metoprolol, and in that population, digoxin wins. It's kind of did I give the digoxin talk here in years past? I can't remember, but one of my talks is on revisiting digoxin, right? One of the oldest drugs in our armamentarium, and it's having a resurgence because it actually is a really good drug as long as you don't overdose people. The problem with digoxin in the past is that we were making people intoxicated with digoxin because we didn't know how to use it. We gave too much, and it created problems. But if you give low-dose digoxin, it works terrifically. So if the guy was having AFib, obviously anticoagulation, echo, all those things, but a good rate control for AFib is actually digoxin. It's better than the other drugs listed.
Now, if I had this as a 40-year-old, then digoxin, its effect is blunted when they're active, any high sympathetic tone, because
Yeah, but in the heart failure world where they have chronically elevated sympathetic tone, it actually is head-to-head randomized. It's the best rate control for heart failure. Now, there haven't been randomized trials of normal people that have palpitations, and digoxin's not very useful for sort of normal palpitations.
Right. And that was what I was thinking of when I brought up this question. All right, the next question doesn't have a question and answer session, but I wanted Dr. Wright, who essentially has a huge heart failure clinic, to comment on below. Now, core current guidelines directed therapy for heart failure with reduced ejection fraction, HFrEF, or less than 40%, include the 4 pillars, or all are class 1 agents: ARNI, beta blockers, MRAs, SGLT2 inhibitors. You mentioned digoxin. A couple of the other things, we don't think about IV infusion, at least I don't. What are your thoughts?
That's because you're smart. Yeah, IV infusions are palliative, right? So if you're sending somebody home on dobutamine or milrinone or something, you've basically thrown in the towel. Or you're trying to buy time for their transplant or LVAD or whatever it is. There's just no role for those. And starting my career, all I did was inotrope therapy. I haven't put anybody on inotrope therapy in a long time, right? It's the reverse, right? You don't want to whip a dead horse. So the 4 therapies are for sure what we should be basing it on for reduced AF heart failure. And, you can prioritize depending on why somebody has reduced AF heart failure, so it's different if they have ischemic dilated cardiomyopathy. But I'll give you an example. If everybody comes in with heart failure, whether you have a thick heart, a thin heart, a low EF, high EF, we genotype everybody. And if you have a low EF heart failure due to a titin mutation, which is the most common of the mutations because it's the biggest protein in the human body, and there's more vulnerability in terms of amino acid substitutions there, those people have an incredible response to beta blocker therapy. Their EF goes up 10, 15, 20 points. And so for those people, it may be they come to me with an EF of 40, they're at 65, and all they need is a beta blocker. We don't fully understand the molecular mechanisms of it, but that's plausible. Otherwise, the theory is everybody should be on all 4 drugs. And then, of course, you mentioned this earlier, who wants to be on a 5th drug, a 6th drug, an 8th drug, a 10th drug? Can't we prioritize? And the truth is we can't yet. We don't have the knowledge to be able to prioritize. But we do know that there's a role for what I would call the small pillars, right? These 4 drugs are the big pillars. The small pillars are listed below. They're not all listed here. There are others. But if you go down them, if somebody's doing well on the 4 pillars, let's say their ejection fraction went from 35 to 52, they're asymptomatic, their NT-proBNP's 200, they don't have an elevated troponin, they're doing all normal activities, they're not having arrhythmia, I wouldn't do anything more. But if they have still symptoms or an elevated NT-proBNP, or they have a suboptimal response in terms of improvement in their left ventricular ejection fraction, then we pull out the small pillars. Digoxin for sure, we should be revisiting it, half the dose we used to use. The problem with the DIG trial, the first trial, 7,000 individuals randomly assigned to digoxin or placebo, all of them in sinus rhythm, and it showed no benefit in mortality. It showed reduction in hospital stays. The problem with the trial is we overdosed people, and if you look at the serum DIG levels in the trial, those people that had high DIG levels actually died at a higher rate. The people at low DIG levels had a mortality that was substantially reduced, both in men and in women. So the lesson there was we did a huge clinical trial, but we didn't know what the right dose was, turns out. So we use DIG now, but we use it at half the prior dose. And that's true both in sinus rhythm and in atrial fibrillation. I don't use IV infusion therapy. There are data now that the 2 potassium binding agents, there are 3 potassium binding agents in the United States. 2 of them are approved for chronic use, and those 2 do lower potassium by about 1 point. And of course, one of the issues when you ask docs, how come you're not using spironolactone more often, or how come you're not using some of the ACEs and ARBs in your heart failure patients? They say, well, the potassium was 5.4 and I was nervous. So if you put somebody on a potassium binding, you lower it by 1 and it's down to 4.5. The sweet spot for potassium is in the high 4s. In terms of, if you look at the outcomes trials, if your level's 4.6, you do better than 3.6, and you do better than 5.6. So we run people between 4.5 and 5.2 in our clinic, and if somebody's up in the 5.5 range, we put them on the potassium binding agents. They're oral, they're easy to take, and they're uniformly effective. A few GI side effects.
So better to put them on it rather than discontinuing the...
For sure, and that's actually been shown. It allows you to use the ARNI and the spironolactone, et cetera, just get their potassium down. Ivabradine is a terrific drug for the appropriate patient, and that's somebody who has not responded to your liking to a beta blocker. So somebody's in sinus, it's only for sinus, not for AFib, but somebody's in sinus rhythm, they have low ejection fraction heart failure, you put them on a beta blocker and their heart rate is still too fast. What is too fast? Turns out it's greater than 70. And it's striking, but in the trial that looked at ivabradine, and this was a randomized trial, for the people who had a heart rate, and the heart rate, it was determined by EKG. And that's an important distinction because when somebody first walks into your office, the MA or you or whoever takes their vital signs and you'll have a heart rate. And then they lay down and they get the EKG done. The heart rate on the EKG is always lower than in the vitals when they first walk in. So the decision about what should I do about a beta blocker dose or ivabradine is predicated on what's the heart rate on the 12-lead EKG. If it's 74 versus 70 versus 65, that little difference, which you would think, 74, what's the big deal? That difference is about 25% mortality. It's huge. So we push very, very hard to get the heart rate into the 60s. That means we're going to use beta blockers at higher doses than are conventionally used. It may mean we use 2 beta blockers. It may mean we use a different beta blocker. Because in this room, there are multiple polymorphisms of the beta receptor. There will be people here who respond better to one beta blocker than another. And that's due to molecular differences at the binding site. Good example, metoprolol, right? In the heart failure trials, the average dose of metoprolol succinate, long-acting metoprolol, was 159 milligrams. The average dose used in the US today is about 50. So we're probably underdosing most people. 5% of the population needs more than 200 milligrams. That's the strongest strength that's made. So I have people on 400 milligrams of metoprolol because that's what it took to lower their heart rate. If they don't respond to metoprolol, try bisoprolol, try some other beta blocker. If that doesn't work, try ivabradine. What does ivabradine do? It goes directly to the SA node that's where the pulse comes from, right? And it affects a channel there that is the signal that generates the heartbeat, and it lowers heart rate. And you can dial down the heart rate, 5 or 10 milligrams of ivabradine, to get it down into the 60s. And for some people, that makes a huge difference. I mean huge, where their EF now goes back up. Similar, what I would call a niche drug, Verquvo or vericiguat, is a guanylate cyclase inhibitor, which is a vasodilator basically. But that helps people with heart failure if they're sick. If somebody's already better, they don't need the drug. But if they've had recurrent hospital stays, they have a low EF, particularly if the EF's down still around 25%, we use that drug. There are convincing data of morbid and mortality improvements on that drug. But it's considered a niche drug for people who haven't responded to conventional therapy. And the last two that are listed, so listed above in the core 4 are the SGLT inhibitors. And notice I didn't put the number there because the SGLT2 inhibitors, DAPA, EMPA, and there are others as well. There are half a dozen in the world. And then there's sotagliflozin, and PEFA is the brand name for that, and that's an SGLT1 and 2. What's the difference? The SGLT2 receptor is in the kidney and also exists in the heart. The SGLT1 is the sodium glucose transport receptor in the gut primarily, and hence you reabsorb sugar from the gut, or you can eliminate it into your stool, glucose. So sotagliflozin actually has quite robust heart failure data, and is one of my preferred. The problem is insurance coverage for it, particularly because one of the SGLT2 inhibitors went generic last week, and hence now the price has fallen for that. So that's the role there. And then for finerenone, that's for, not for this guy, because this guy had reduced EF heart failure, but for preserved EF heart failure, they're convincing data for the mineralocorticoid receptor antagonist finerenone. For those of you in the know, we've been using spironolactone for a long time, even though the data don't support it, and unfortunately the big spironolactone trial from 2 months ago came out and showed no benefit in preserved EF heart failure, which is very disappointing for us because we figured it would be helpful, and it proved to be no better than placebo, unfortunately. So for preserved EF heart failure, there is a role for the MRA finerenone.
So for reduced heart failure, talking about spironolactone, 25 milligrams versus 100 milligrams.
Yeah, we don't know the dose, and part of that is the clinical trialists, hint, hint, most clinical trials, they aren't designed to find what the perfect dose is, unfortunately, because think about it, to answer, is it 12.5, 25, or 50 milligrams of spironolactone that'll be better? Your trial is just doubled, quadrupled in size, and that means the expense and the duration and all those things. So there are people, Bert Pitt being the prime example of somebody who believes that higher doses are better, but in the clinical trial data, that's not supported. So most clinicians will use low-dose spironolactone, 12.5 or 25. If you talk to the hepatologists and things, why do they make a 25, a 50, and 100 milligram dose of spironolactone? Because for cirrhosis and other indications, those higher doses are often needed to fully block the receptor you're trying to block. But conventionally, we use 12.5 or 25 milligrams daily of spironolactone.
All right. Next question, page 8. While we treat heart failure with mid-range ejection fraction, EF 41 to 49%, similar to HFrEF, which agent has the strongest evidence in reducing heart failure hospitalizations and cardiovascular outcomes? Mid-range EF.
I don't hear the music.
Okay.
An educational opportunity. Okay, so let's go through these. So first of all, where did the terminology low ejection for mid-range ejection fraction, preserved EF, and I've even invented HEF, which is high ejection fraction heart failure. Those are the hypertrophic cardiomyopathy patients with heart failure. It turns out that came from the clinical trialists, because we were first designing, this is back in my Brigham days, we were designing outcomes trials, and we said, let's pick the people who are most likely to die because we're trying to prevent death, and who are those people that are the lowest EFs? And so we literally randomly chose 40. We voted on, should it be 35? How about 40? How about 45? And we chose 40 without any biologic justification, to be honest, okay? So there's nothing magical about an EF of 40. 41 to 49, which is listed here, is low. I'm hoping nobody in this audience has an EF of 41 to 49, because the lowest for standard deviations of echo-based EF, for a man, 2 standard deviations below normal, it's 52%, for a woman it's 56%. So these people, by definition, have low ejection fraction, even though we call it mid-range or other terms that you can use. So in that group, okay, the higher your ejection fraction, the less benefit there is with beta blockers. That's been shown with certainty, okay? I alluded a moment ago to the MRAs. There is actually evidence in this group that MRAs are helpful. ARNIs, ACE inhibitors, and ARBs, again, the higher your ejection fraction is, the less good these are with regards to improvement in clinical outcomes. The firmest data are with ARNIs, and interestingly there, if you're a man and your EF is 50, there's no benefit of ARNIs. If you're a woman, there still is. So there's a little gender. It's one of the few drugs in the heart failure arena that has gender-specific data that came out of the big trials there. When we presented those data to the FDA, they didn't know what to do with that, because they're reluctant to put in a package insert, this is good for men versus women, and they said maybe it's an artifact of, so they just gave a general blanket statement that you could use an ARNI for preserved EF in mid-range ejection heart failure, but I will just tell you that it works less well in men. So the appropriate answer here is SGLT2 inhibitor, or SGLT inhibitors, because you could use a 1,2 inhibitor. And those SGLT inhibitors, at least up to an ejection fraction of 70%, whether your EF's 20, 30, 40, 50, or 60, and you have the heart failure syndrome, you benefit from an SGLT. So they have emerged as, if you just plug in heart failure syndrome, meaning you have biomarkers and structural abnormalities and you have edema or breathlessness, then the core drug would be SGLT, because it's regardless of EF except for the highest EF people, which are the hypertrophic cardiomyopathy patients where we have a paucity of data.
So your heart failure syndrome, the strongest evidence is the SGLT2 inhibitors. It's a class 2A indication. Yet only about 17 to 20% of patients across the heart failure spectrum on SGLT2 inhibitors?
That may change because of the generic availability. I mean, one of the problems, of course, is cost and insurance pushback and PBMs and all those types of things that make our life, especially with him ordering a lot of GLPs, it's a problem. You know?
No, not for the patient.
Yeah, no, yeah, it's a problem for the patient, not for you. Yeah.
All right, I have another question for all of you guys. It's a class 2A indication in the United States. It's a class 1 indication in Europe. Why are they ahead of us? Same thing with LDL reduction in recurrent events. Europe recommends an LDL of 30 or less. And in the United States, we're still not catching up.
Part of the reason for that, Mo, is that we have more stringent rules, okay? So when I spent 2 years writing that first guidelines on heart failure, we were told we could not put in there, unless we had 2 randomized double-blind placebo-controlled trials, we couldn't put in level 1 evidence on anything. The Europeans don't have that restriction, so they have the ability to use what you might term expert opinion or extrapolation or reading between the lines kind of thing, and that's what they do in their guidelines. So they do tend to be ahead of us, but with the potential downside that what they put in their guidelines may not actually be true.
And I would say the National Lipid Association has mirrored what the Europeans have done for years now. I think, that stringent criteria to only use randomized controlled trials or meta-analysis of randomized controlled trials led to at least a decades-long misrepresentation of the biology by saying, well, the studies just looked at moderate and intensive statin therapy. So it just used moderate and intensive statin therapy. And even though I know the authors, you included probably, didn't intend to throw away the targets, because each of the randomized controlled trials sequentially showed lower and lower LDLs as being beneficial. But it led to I think a handcuffing of the committee and what came out of the guidelines and what people understood. So I think you can use non-randomized controlled trials, to make decisions that can get into guidelines. It's just that the HA has not historically done that.
Yeah, and you may be able to list it as level 2, or something. I'd be interested in our clinical trialists, because, as I said, the design of the trial then impacts downstream these clinical things. And, I jokingly say when I lecture about this that there were no left-handed Lithuanians in the trial. Therefore, we can't recommend the use of this drug in those people because they weren't in the trial. So we have to, 90% of what I do is not supported by randomized double-blind placebo-controlled trials because you can't try everything.
And that actually I think is a very important part about decision-making, clinical decision-making by doctors. I mean, if all you needed to do is follow that highest level evidence, you could have an AI machine follow an algorithm and do it for you. But you're right, every patient you have doesn't have a randomized controlled trial behind it to tell you what to do in that situation. That's the art of the medicine. And you can use the PCSK9 inhibitor outcome studies to show benefit in terms of cardiovascular risk events at levels down to 10 to help guide you and people who you don't have to stop at some place. So I think we're just more conservative here amongst our leading societies, and that's not just true for HA, it's also true for the ADA too. But the art of medicine allows you as providers to take your knowledge that you gain to try to tailor it to that patient.
Well, and as my point earlier about beta blockers, I tell people, I have some people on 400 metoprolol. Oh my God, that's not in the package insert. That's not in the clinical trials. Well, guess what? That's why you're a clinician. That's why you're supposed to use the best information you have for your patient. I want to hear from our clinical trialist here.
Well, yeah, no, I think what's interesting, so there's a famous study that came out actually more than 2 decades ago that was just taking an existing trial and showing that if you just look at horoscope, that you can identify 1 or 2 horoscope, zodiac signs that might benefit more from certain treatments. And so there's a conundrum in cardiology especially, but also across other sciences, that when you design these trials, they're designed and centered around a single endpoint. And if you don't hit on that primary endpoint, there's almost a naysay that you can't go digging deeper into some of these other outcomes. And what you've seen throughout the day is that whether you hit that primary endpoint, there are many more important things to glean from these trials. And not only that, whether it be differences between men and women, differences by levels of X, Y, and Z, or existing conditions. So there is much more of an art to it than the reliance on one or two trials that might go through, whether it's ESC, AHA, ACC, et cetera. So I think it's a real challenge, and my hope has been actually over the last few years that we need to kind of revisit how we approach the trials themselves so that we can provide the most comprehensive answer to the questions that they're trying to pose.
And do you think that that means that big data and analyses of 17 million charts and all that, and AI, will that not replace you? I know you're irreplaceable, but will it give us some additional information above and beyond randomized placebo trials?
Probably not. Well, so there's a concept called target trials or target trial emulation, just to your point, where you can take kind of what we call real world data or real world evidence, or it's essentially taking observational data and trying to soothe it in a way using AI and other machine learning techniques to try and see if we had done trials within this population based on existing or repurposed or kind of pleiotropic effects from different medications. Those findings haven't necessarily aligned so far with trials that are then subsequently done to see if that was actually true or not. That being said, the world of machine learning, AI, et cetera, is evolving quickly. And so is it possible that, a certain number of years down the road that could be the path to identify, new indications for specific medications or to try and carve out these new spaces? Yes, I think inevitably that's going to happen, but we're not there quite yet.
And do you think that'll be sufficient for FDA approval of agents and indications, or do you think it'll just tell you, here's a trial you should do?
I think the drug companies will enjoy it because it will give them the leads that they need. The FDA historically has been a bit of a stick in the mud, shall we say, in terms of process and procedure. Will that change? It typically changes like 10, 20 years after the field's already moved on. So I think inevitably FDA could open up toward that a little bit differently, but I don't see that happening anytime soon.
We've been getting involved with a few clinical trials at our office. So what are your thoughts on it? Do placebo patients, do they benefit from participating?
This echoes back to what we were discussing a short while ago, and one of my favorite papers I published wasn't in fact a clinical trial, but was in fact a study showing that if you just are eligible or willing and able to get randomized into the trial, that as you get through those different steps, you're going to live longer. So just a simple tagline, you don't want to say enroll in a trial, live longer. Well, that kind of behooves the exact intent of why we try and randomize people into a trial. It's what we call equipoise, right? We have genuine uncertainty as to whether or not a given intervention is going to be superior or inferior or something in between relative to an existing treatment modality, whether it's a placebo or standard of care. So, but to that point, when you get people to know that there are these types of studies happening, whether it be within a practice or within a healthcare system, and not just kind of fly-by-night stuff, it gives people a different sense of purpose, is what I've seen. What I've seen, at least working within the hospital system, people recognize that there's importance with the work that's being done, not just on a clinical level, but trying to understand what we do next. And I think that's especially true with cardiology.
Thank you.
Yeah, as we said before, if you look at standardized patient-reported outcomes, I'm not going to talk about biomarkers and things, but for patient-reported outcomes, uniformly, if people enroll in a randomized trial, they feel better and do better initially. Kansas City Questionnaire, which we use on 100% of our heart failure trials, clearly shows that in every trial. So you have to do a placebo-controlled trial because is the delta of their improvement the same as placebo or better than placebo? That's really the question when we're doing heart failure trials contemporaneously.
Actually, one other quick, so with the KCCQ, what's interesting is that we see this with cognition and other outcomes when it's patient reported or even if it's measured. First of all, the placebo effect is real, but usually what ends up happening is that you'll see both groups or whatever number of intervention arms, so everyone's improving. The question is whether you're improving above and beyond kind of this training effect in your own head that like, oh yeah, I'm taking something that must be doing good and therefore I'm going to move a little bit quicker, or pacing is going to be a little bit different too. And we see that with cognition especially. You start to, you get quizzed one time, you get humble pie, big time, and then you realize the next time around you're prepared for it. And it's no different than some like, whether it's Kansas City or some of the other assessments.
Well, there was a famous trial where they convince people that this pill would improve sexual performance in men, and it was a placebo, and if you convince men they're going to do better in bed, they do better in bed.
All right. Moving on. Next, question 9. 68-year-old obese woman with dyspnea, lower extremity edema, and crackles on physical examination. The patient's BNP is normal. What would explain the patient's normal BNP? There's no drugs on this question, but I wanted to highlight BNP, interpreting BNP. Okay. Pretty darn good, right?
Yeah, so those 64% of you, congratulations, that's the correct answer. So first of all, obviously somebody who's short of breath and has lower extremity edema, could they have pulmonary embolism? I guess, right? But they wouldn't have RALs if that's what their crackles are. So this is a patient who has the clinical syndrome of heart failure, as best can be told by physical exam and history. And the BNP, so go back in history when the BNP was first developed, and still the national coverage determination for BNP was predicated on a single trial that was looking at the VA population of people who presented to the emergency department with the complaint of shortness of breath. And if the BNP was below 100 and their shortness of breath was their complaint, the likelihood that they did not have heart failure was quite high, and therefore the negative predictive value of this test in that particular setting and population, that's how the thing got approved, and that's still the coverage for Medicare, even though it's grossly out of date now. What they didn't understand then is that obese people have different metabolism of the biomarker BNP. It's a natural hormone, but they have spuriously low BNP values in obesity. It's not true of NT-proBNP as much, which is why in the heart failure studies we do, we never use BNP anymore. We only use NT-proBNP. And believe me, you will have people with heart failure who have a BNP that's, your lab will say normal, it's 140, who will have an NT-proBNP of 4,000. I mean, that's why we do not use BNP, and I would strongly recommend nobody use BNP anymore. You can still use, I guess, CKMB to diagnose an MI, but why would you when we have troponins now? So we have an NT-proBNP, it's a better test. But this is in the preserved EF heart failure trials of obesity, the typical person in those clinical trials had a normal BNP. And that tells you a lot, because they had heart failure enough to get into a randomized trial, and yet their BNP was normal. So it's no longer considered good enough to exclude heart failure if you have a normal BNP in the obese population.
Okay, next question. Do interrupt us if you have any questions. Okay, moving on with cardiac drugs. 50-year-old with a blood pressure consistently around 140 millimeters of mercury systolic. No other comorbidities. Which antihypertensive agent would you recommend? Now, some of this came up in the talk, so let's see what you all have to say. Okay. Okay, so I'll give you my opinion, and I want all of you to tell me what you think. The purpose of this question for me was, why would I want to use an ACE inhibitor over an ARB? I mean, I know most of the robust data came with ACE inhibitors, but as you mentioned in your lecture, less angioedema, more tolerable, less cough. Why would I want to use an ACE inhibitor? And for vascular protection, I generally go with an ARB initially. All right, Richard, what do you think?
I don't think that's wrong. You know,
Not necessarily right, but not wrong. That's like it's non-inferior.
yeah. So of those 5, I mean, I think that the 2 that would be considered in modern A, B, or C are all reasonable, I would say. I agree what you said, and what I said in my lecture is that ARBs are better tolerated than ACE inhibitors. They're generally considered roughly equivalent in terms of nephroprotection and cardiovascular risk reduction, et cetera. I mentioned losartan is the least powerful of the ARBs, and probably nowadays the better ARBs would be preferable because they do have head-to-head. We did head-to-head trials and showed that, as I mentioned, azilsartan and olmesartan are better than losartan head-to-head. They're just better, stronger and longer acting, et cetera, et cetera. And they may also be dosing, because most people on losartan are on a relatively low dose compared to coverage of the ARB. But I would argue that with the 47%, the plurality people in the audience, that amlodipine is a really good choice. And it's one of the reasons it's the most commonly used drug in the world, actually, for hypertension. It doesn't have any metabolic consequences that we know about, unlike hydrochlorothiazide. It doesn't have depression and fatigue and stuff that would be the beta blockers. It doesn't cause hyperkalemia, potentially, like the ACE inhibitor or the ARB. So, and it has better, as I showed you in the head-to-head trials, it has better data with regards to superior blood pressure reduction in a dose-dependent fashion and continued benefits with regards to reduction in cardiovascular events. So I actually would vote along with the rest of the people that I think amlodipine, when used at an appropriate dose, is a very good choice here.
So if you...
There is a question in the audience too, by the way, over there. Edema is 100% dose dependent in a geometric fashion, right? So it's not linear. It's much more common in women. So you're right. If you were to go out of the gate, this is a man. He's a little less likely to have edema. But if you had a 50-year-old woman and you put her on 10 milligrams of amlodipine, there's a 35% chance of ankle edema. It's sometimes quite striking. And that's totally dose dependent, so you can get by in 2.5 or 5. And 2.5 or 5, you're only sacrificing a few millimeters of mercury or blood pressure. So low dose amlodipine or mid dose amlodipine is exceedingly well tolerated, and you don't need any further blood tests. You don't have to check their creatinine and their potassium, all that kind of stuff, which is one of the reasons I think 47% of the people voted for that drug.
Although we don't know if this was a man.
You're right. 50-year-old, we don't know.
Yes.
If you use losartan, do you generally dose twice a day?
So the question is losartan twice a day. So in the hypertension world, normally it's QD. There are data from the blood pressure, from the heart failure world, where BID is better because it's a short-acting drug. So the standard dose for heart failure would be 100 to 150 milligrams a day. It's largely been replaced by other ARBs. But if you were going to use losartan, that would be the dose in heart failure. For hypertension, though, most people just use it QD. And because the dose 50 or 100 have essentially the same side effects, I mean, to me, 100 milligrams a day, it still will be beaten by olmesartan or azilsartan if you were going to use an ARB.
What about valsartan over losartan in heart failure patients?
Valsartan over
BID.
losartan, well, there are more robust data with valsartan than with losartan for sure in the heart failure world. And obviously, the ARNI includes valsartan as the drug that's in that. Now, part of that is because who owns the patent and all those types of things when you're making the determination of it. And there's a reason why it's BID. I mean, these are relatively shorter acting ARBs. If I were to repeat that trial, I probably would have used a longer acting ARB, frankly, but you know, from 10 or 15 years ago, and valsartan's still a good drug.
Side effect of cough, that's annoying, but the ARBs have this angioedema, which having dealt with that before in a rural emergency room is pretty terrifying. I can imagine if somebody's out, you know, on a camping trip and suddenly get that after some years. I mean, that's a potential life-threatening event.
I'm going to turn to my diabetologist here to have him give the opinion about that. But so part of it is just so remember when the ACE inhibitors were first, they came out first, right? And so historically when something comes out first, you have a longer, and there are more studies and things like that. So, but the downside though, and I remember vividly, one of the first patients I put on long-term ACE inhibitors on my heart failure program had an intractable cough. And I did a world literature search, and there was nothing listed as cough as a side effect. The guy ended up getting a lung biopsy for cough, intractable cough. And then he came to me and he says, Doc, I think it's that pill you put me on. I said, geez. And it was, and I mean, that was 40 years ago, and I remember it to this day because I thought, how stupid could I have been? And that's one of the advantages of the ARB. Angioedema is actually more common with an ACE inhibitor than it is with an ARB. So anybody can get an allergy to a drug, but the ARBs are considered easier to take and safer than an ACE inhibitor. Now, there are minor nuances. I don't know, from the diabetic, kidney protection, endocrine perspective, do you prefer an ACE inhibitor or an ARB? Or do you not care?
We go through the same decision and discussion. I think both ARBs and ACEs have shown protection on the kidney. I think even diabetes risk reduction as well. So I don't distinguish unless they have side effects. I just historically have always used an ACE inhibitor, and then I switch to an ARB if they have side effects.
Yeah, this was a little more important when only one of them were generic. Now they're all probably equally cheap.
Just a quick question. Do the calcium channel blockers protect against proteinuria? I'm not aware that they do.
Yeah, they do.
They do? Okay.
Yeah, there's some old data that, protect against. If you put them on, if somebody has albuminuria, it goes down.
Yep.
So, it seems to be almost every antihypertensive, if you lower blood pressure effectively, will have some benefit in terms of albuminuria reduction. I'll ask you, because this came up during the break here. Do you chase albumin to creatinine ratio? In other words, let's say somebody comes to you and they have an albumin to creatinine ratio of 100, and you put them on appropriate therapy and now it's 70. Most of the drugs that we use lower it by 30% or something like that. Is 70 good enough, or would you add another drug to bring it down to 40 and then another drug to bring it down to 25?
Great question. Great question that we don't have an answer for. And I would say in looking at the outcomes data on the clinical trials, and just seeing what happens, if I can stabilize whatever metric I'm following, eGFR or proteinuria, I'm happy with that. I would say, and this question came up when we were talking about it up there, if I put someone on one drug, I don't put them on all three at once. I'll put them on one drug, see if I can stabilize or maybe see that slight improvement like you were saying before, but then follow them every 6 months or a year after that with continued monitoring. And if it continues to deteriorate at that point, then add the second one in. So I just do that as an art of medicine rather than any particular evidence behind it.
Second question I have for you. So in the heart failure world, we don't rely just on creatinine for our eGFR. We use cystatin C, and part of that is because of these heart failure patients that have, frailty and sarcopenia and their protein intake, et cetera, et cetera. So are you in the diabetes world using the combination of cystatin C and creatinine to come up with an eGFR?
I have been swayed by my nephrology colleagues, and I'm using more cystatin C. Yeah, especially in the older population where they have sarcopenia. Obesity, sarcopenia is a big area that we talk about a lot. I just find it more consistent.
How do you use it? I don't have any experience with it.
It's really important if you have a geriatric practice. And I'll tell you, you'll see these, they're usually small, older women, and they come in and their creatinine is 0.6. And then the lab tells you their GFR is like 87, and you go, no way, And then you do a cystatin C and you find out that her GFR is 35. And you'll see that over and over again. So the KDIGO equation incorporates cystatin C and creatinine to come up with a more accurate, validated by 24-hour urine, because most of us don't do 24-hour urines to actually measure GFR. It's all eGFR. But if it's based just on a creatinine, you will be seriously misled. And you can be misled the other way too. So we did an analysis of Gold's Gym dudes, and when they're like, protein and creatine, and they come in like this, and their creatinines are like 1.6, and these dudes have so much muscle, and they're eating so much protein that's just a reflection of protein breakdown and not necessarily of renal dysfunction. So on both ends of the spectrum, the creatinine is misleading.
Good to know.
Dr. Wright, have you noticed hyponatremia, especially with the losartan?
So hyponatremia was the question. It's common, and it's one of the banes of my existence, because in the heart failure world in particular, it's really common to have hyponatremia because most of them have excess antidiuretic hormone being secreted as one of the neurohormonal changes that accompany heart failure. And in the heart failure world, it's a significant prognosticator. So if your sodium is low, you're going to do worse. Okay. Now, what we don't know for sure is if we correct it, and we do have the ability to do so, does that translate into improved outcomes? We don't know that, but it's definitely an adverse prognosticator. Many of the drugs that you and I use can aggravate hyponatremia. Of course, the common one are the thiazide-type diuretics, and so there are many people who you might want to put on a thiazide-type diuretic, but every time you do so, their serum sodium goes down to 129 or something, and then in those people, you really have to avoid those. The centrally acting antidepressants also aggravate it. There's a smaller incidence in the MRAs, so spironolactone, eplerenone, and finerenone all can cause hyponatremia. It's about 1%, but it's real there. That's much less, though, than with the thiazides. I haven't really seen that with ARBs or ACE inhibitors. I don't know if you guys have, but if you think about why do we put people on these drugs, they have metabolic issues that lead to hyponatremia. I actually have a lot of people on chronic tolvaptan, which is it's the blocker, the oral antagonist of antidiuretic hormone. And when you have somebody with SIADH, for example, I've had people with serum sodiums as low as 99 in my heart failure world, and those people, you have to put them on an ADH antagonist. It works incredibly well. It's just very expensive, and most of the PBMs won't pay for it unless they've been hospitalized with hyponatremia, et cetera, et cetera. But there is a solution to hyponatremia, not just avoiding the drugs that aggravate it, but actually treating it directly.
Okay, next question. One of my favorite questions. A 62-year-old with a blood pressure reading of 162 over 100 millimeters of mercury in your office. Home blood pressure reading averages about the same, 160 over 90. The patient is asymptomatic. Physical examination is unremarkable. What's your best treatment option? Okay. I like the answer. Rich?
Yeah, for sure, that's the right answer. And we have the benefit in the hypertension world, which we don't have in many other. They do in diabetes and we do in heart failure, but we have multiple combinations for treating high blood pressure. And the so-called poly pill, and there are now numerous trials that show that conventional therapy, where you start with one drug, see how they do, add a second drug, see how they do, add a third drug if you need it, et cetera, doesn't end up being as effective as just right out of the gate starting combination therapy. This person, if you're trying to get down to 130 or below, there's no single agent on the planet that's going to lower them from 160 to 128 or something. It just doesn't, there isn't anything. So they're going to end up on combination therapy anyway. And of course, in terms of pill burden and procurement cost and et cetera, and even buying compliance, I would argue starting a combination therapy right out of the gate is the right thing to do. And they're double and they're triple combinations that you could use. This person for sure will end up on at least double therapy, so I would put them right out of the gate on a combination pill. No, and in fact, the treatment, the studies that where they did what they call standard therapy, which is you start with one, et cetera, versus combo out of the gate, all show that combo out of the gate, and there are multiple such studies, is better. It's actually not only better, it's as safe. There isn't any downside. Now, you could argue, you don't know the guy's potassium, et cetera. That may influence your choice of drugs, but simple enough to get a chemical panel on the guy and the next day start therapy. You don't have to start it today. One of the things here in the, send patient to the ER. I would never send a patient to the ER at a blood pressure of 160 over 100. That's a total waste of resources. If it's 250 over 120 and they're in papilledema, okay, but I mean, we don't see that anymore. So almost never, and I'm on call for 23 cardiologists. I get these calls every night. My blood pressure's 160. And I say, well, you turn over and go to sleep, and we'll see you tomorrow. You don't have to send somebody to the emergency department for this, for sure.
Yeah. There's a difference between a hypertensive urgency and a hypertensive emergency. So, all right. Yes, please.
Don't we run the risk of rejection of both drugs if the patient is not compliant, has some side effects?
Can you repeat the question again, please?
So if we initiate combination therapy at first, let's say the patient goes home and has some sort of side effect. Now, have we not condemned two drugs at the same time?
Yeah, so the question is, if you start combo therapy and somebody has an adverse effect, how do you know which drug? I mean, most of the adverse effects, because you're a smart clinician, if somebody gets hyperkalemia and you put them on amlodipine, benazepril or something, it's going to be the benazepril. Similarly, if they have a cough, and if they have pedal it's the amlodipine. So you can usually figure it out. I would agree with you that there's an occasional person who gets a rash, and you go, "Oh, rash," It's like, I don't know. It could be either drug, and most commonly there are certain drugs that are more likely to cause rash, etc. But weighing all those things, I think the correct thing to do in this patient still is to use combination therapy.
How often are you looking for hyperaldosteronism?
Yeah, that's a good question. I actually pulled my slides out of my talk about that. But so the question is, how often, or I'll rephrase it, do I ever look for hyperaldosteronism? Okay. So I'll just tell you that the latest data would strongly suggest that something like 20% of all the people that come in with elevated blood pressure actually have hyperaldosteronism. The question is whether that matters, right? Because and I'll tell you that the people at my institution that do the unilateral venous sampling and take out, they want to do things, but the truth is that if you just give medical therapy like an MRA or something, and the person's blood pressure normalizes, it's almost irrelevant whether they have hyperaldosteronism as the genesis for their high blood pressure. So I treat the biomarker of blood pressure in those people. Now, it's true that if somebody is an outlier and they're not responding appropriately to therapy, and you're sure they're taking it, it's not, there are people who will claim they're taking it. We do clinical trials. I'll tell you, we would do pill counts, and then it turned out one of my patients was dumping all his pills down the toilet because he wanted to come in with an empty pill bottle to convince us he was taking his pills, which is why in those trials we were doing when was the last time you sent a serum hydrochlorothiazide level? We did those to make sure the patient was actually taking the medicine, right? But barring that, I don't measure. You can do so, but I just give spironolactone or eplerenone or finerenone and call it a day, honestly.
All right, next question. Which of the following is the most common cause of resistant hypertension? Okay. Pretty darn good. Richard?
Well, it's definitely not renal artery stenosis. I'll tell you that for sure.
Answering it like a board question.
And
It's definitely not.
It's definitely not drug or alcohol induced, although, yeah, I guess if you're having a cocaine addict or methamphetamine or something. So the question comes down to whether it's obstructive sleep apnea or primary hyperaldo. Now, as per the question asked a moment ago, 20% of people with resistant hypertension have hyperaldo. And we learned that the hard way in the renal artery ablation trials, where renal artery ablation is a great way to treat white coat hypertension, but it turned out unless you try a mineralocorticoid receptor antagonist, and my favorite because it's inexpensive, et cetera, spironolactone, you won't know whether somebody has primary hyperaldo, because most of the time, even with normal renin-angiotensin and aldosterone levels and stuff, it's not that easy to parse it out. So we just do the biologic experiment of giving an MRA. And most of the people would say, and you can't make a diagnosis of the resistant hypertension, the standard is you have to be on 3 drugs, and at least one of them is a thiazide type diuretic. In our clinic, I won't call them that unless they're on an MRA, because what you'll find is you put them on an MRA, and bingo, their blood pressure is normal, and they really had hyperaldo. You just didn't know that they had hyperaldo. Now that said, obviously sleep apnea, I alluded to this when I talked about nocturnal hypertension. One of the main causes of nocturnal hypertension is the catecholamines that get released during sleep apnea. So if somebody does a 24-hour ambulatory blood pressure and they have hypertension at night, they all get sent to the sleep lab, and about half of those people or more will have significant obstructive sleep apnea, and if you treat them, their blood pressure will come down with CPAP. So it is one of the indications of it. I'm just not sure that it's the, quote, most common cause of resistant hypertension. I think on a board question, I probably would have answered B, primary hyperaldo.
Yeah, I think primary hyperaldo, in my experience, is pretty rare. I mean, you see secondary hyperaldo.
Yeah, I guess it depends how strictly you define primary. If you got rid of the primary word and just said hyperaldosteronism.
Right. So if renin levels are less than 1, I mean that's primary hyperaldosterone. But you'll see renin levels 5 to 10, aldo levels above 16, and that's kind of a physiology. The reason why I didn't go to nephrology is because I'm completely confused by all of those. It just even gets worse. They have not come up with a good way to explain nephrology. All those channels and ions and things like that. Like why lowering potassium makes you pee out more sodium. I still don't understand that. But when you're exactly as you said, when you got 3 or more drugs and you're 18 years of age, I generally screen with an aldo and a renin level. And we do want to look at the adrenal glands if someone has an elevation, just so we can follow along nodules. Sometimes they do make more than one thing, and we're looking for that. I want to put a plug in for alcohol. I see a lot of folks who are not responding well to meds, and then we convince them to drop their alcohol intake, and they come right down.
That's because you live in Portland. That's why.
Yeah, we went from beer to distilleries. That's true.
All right. I had a physician, by the way, who consumed a lot of alcohol. And I asked him to stop, and he didn't believe that alcohol would make a difference. And he discontinued, and his blood pressure was normalized. By the way, to Zepbound.
Does alcohol interfere with blood pressure medication? I'm not sure what.
Yeah, because if you're stone cold drunk, you forget to take your medicine. I mean, first of all, if their AHI is 5 versus 50. I mean, there's a difference in if they're obese and all the, I mean, it's a whole spectrum. We have an atrial fibrillation research center, and they're all hip on, and they were sending 100% of their AFib patients for sleep studies. So I was being inundated with sleep studies. And with mild AHI, I have no idea what to do with it, because everybody in this room has an AHI of somewhere around 3, 4, or 5 or something like that. And if you go to 6, they call you a mild AHI. And I honestly, I don't know what to do with that. Now, we do have clinics of dental appliances and all those types of things to do, and this is an active, you know, I don't know if they're company, I think there are companies out here, sleep apnea companies, and there are surgeries and all sorts of stuff. We've been disappointed in the heart failure world, frankly, with treatment of sleep apnea, because it didn't pan out to be as effective as we thought it would be, but I'm open to that possibility. I don't know if you guys have other thoughts about it. Yeah. After the divorce is consummated is what I would say.
No marriage.
There's a reason for that.
I mean, alcohol is not long lasting, right? I mean, once the effect is over, you would know if they stop imbibing. I don't know, not much else. Yeah. All right, and by the way, tirzepatide is now approved for patients who have moderate sleep apnea. Another indication. If the patient has sleep apnea, insurance will cover your...
Well, they may not cover it. That's the problem. You know, FDA indication versus PBM coverage are disparate from each other. So in our experience, it's an indication, and yes, you'd think that would allow them to pay for it, but lots of times they won't pay for it.
All right, next question. Continuing to focus on some cardiac drugs here. A 58-year-old male with an LDL cholesterol of 136 milligrams per deciliter and willing to start statin therapy. Your choice of statin. Okay.
Next question.
I bring this up because over the years, I don't know why anybody would use simvastatin. I've been tired of the pharmacists calling me that the patient is on simvastatin and diltiazem, which increases simvastatin levels. So I decided I'm just not going to use simvastatin. And then looking at the package insert, you should not use more than 10 milligrams if the patient is on diltiazem. So why use simvastatin? I think the audience is good there, right there.
Yeah, there isn't any reason. And as you say, I mean, they were good drugs 30 years ago, but simvastatin has too many drug-drug and drug-food interactions. It's one of the most egregious examples of what happens with grapefruit juice, for example. If you look at serum simvastatin levels taken in concert with grapefruit juice, the blood level goes up 1,000%. With the two, and that's a lot of the cases of rhabdomyolysis were actually due to that on simvastatin. So it was a historically useful drug, but I think it has no role anymore in modern medicine. Pravastatin is too weak, and you know, when pitted head to head against a stronger drug, it lost. And so it should really boil down to atorvastatin and rosuvastatin. Those are the two that we own. Red yeast rice is a minimal statin. It does have a statin in it. Yeah, but it's not potent enough, and it's too small, and it has other organic substances. So the answer here for sure, as 92% of you said, is atorva or rosuva. The most commonly used in cardiology is rosuvastatin.
Yeah, the reality is that patients will start on one. Oftentimes insurance will dictate what you can do as well. And they'll say, I've got muscle aches on this, so we'll switch them to the next one. Theoretically, pravastatin and rosuvastatin have less lipophilic characteristics, so they're less likely to get into muscle to do that and more likely to get into the liver. But yeah, the reality is we do start with atorvastatin or rosuvastatin. Both of them, besides muscle aches and pains, on a dose-dependent manner can increase risk of type 2 diabetes. So that's something that is usually not discussed with patients. It's usually in women and women with a family history of diabetes. So it is a reason why I tend to go with 40 of atorvastatin or 20 of rosuvastatin and then add in ezetimibe to try to lower, because it is dose dependent in that risk as well. But the reality is you're going to start with one, your choice, but then oftentimes the patient or the insurance will dictate switching before going that route.
Yeah, and there are some other nuances. So there is a signal with high-dose Rasuva of some nephrotoxicity at 40 milligrams, and so if somebody has diminished creatinine clearance, that will influence us with regards to dosing. The second nuance here is that there are differences in HMG coreductase structures, and there are some people who are super sensitive to statins. They will be the people who will come to you saying, I can't tolerate, and yes, half of them are crazy and they can't tolerate placebo, but some of them it's a real finding. And if you've seen enough patients, you will see these people. And I'll give you a perfect example of a lady who had tried 4 different statins, who had coronary disease, clearly needed to be on a statin. And she is still a patient of mine. She is on 1.25 milligrams of rosuvastatin once a week. 1.25 once a week, and her LDL fell 70%.
Wow.
Okay? And when she was put on conventional doses, she had rip-roaring muscle problems. So just be cognizant that not all patients are crazy, and you can try, and what I tell these people is I'm going to try nanodose statin on you. I buy into I said, you're very sensitive, we're going to try nanodose 1/80th of the normal dose, and you'll be able to get those people on statin.
How do you get the 1.25?
You break, the smallest doses, they don't make a 1.25, right? So you take a 5, you break it in quarters, and then I'll start those people on once a week. And I've had nobody who couldn't tolerate 1.25 once a week.
Okay, next question. A 56-year-old female with a history of type 2 diabetes. LDL is 110 milligrams per deciliter. Best therapy. Okay. All right, Sabina here, who's done all the work for the conference, told me that I'm looking at all your questions. You never have lifestyle. Everything is drugs. So here's lifestyle for you. But this patient has diabetes. All right, what do you guys think? I chose B, moderate intensity statin.
All right, so the reality is that lifestyle wouldn't be able to achieve an LDL or a non-HDL cholesterol, which I advocate for following patients with diabetes because they have a triglyceride disorder. Typically, it's not a cholesterol disorder. But lifestyle wouldn't be enough to get them down anyway. And none of us would ever say, here's your statin, and by the way, go to McDonald's, and why don't you sit playing games all day? Right. I mean, that's just a false narrative. So we would still say we want you to eat healthy, we want you to be active, and here's your statin. We were just saying to Rich that this is based on the 2013 AHA guidelines. We don't use the word, I don't use it in my practice, moderate or high intensity statin. Basically, the guidelines would say if you're over 40 and you have type 2 diabetes, get your LDL below 70. And by whatever means necessary, in my mind, that could be a statin, that could be Zetia, that could be a statin and Zetia, that could be PCSK9. Do what you can. I would throw in a CAC score in this person, because not that they're to define if they are at risk for needing the drug, but to define what threshold I might get them down to, and start a baby aspirin too.
Yeah, I would absolutely agree. I'm not sure that coronary calcium is a therapy, but for sure to decide how intense. And Matt Budoff he mentioned that, but he didn't mention the one trial that I think will change this, which is the study from last month, a month or so ago, in Korea, which was the very first trial ever done asking the question, if you target a different LDL, are the outcomes different, right? Because before, every other trial was everybody got the same dose or same drug, and then whoever went lowest did best. But that didn't answer the question that if you added a second drug and a third drug, would you actually improve the outcomes? So this Korean trial of over 3,000 people with 3-year follow-up looking at MACE hard outcomes showed compellingly that reducing the LDL target was either 70 or 55, okay? The actual achieved numbers were an LDL of 66 and an LDL of 56, and the people at 56 had a 1/3 reduction in cardiac events. These were all coronary patients. And that's a stunning revelation, because before, if somebody was at 65, you go, good job. And now if you lower them to 55, they do one-third better. I mean, that's stunning. And the difference was that they moved up in dose of statin, or they added ezetimibe, and then I don't know how in Korea how much they use PCSK9, but they were underutilized compared to what we would do in our practice. So we're much more aggressive with lipid control. As was mentioned a moment ago, the LDL cholesterol using the Friedewald equation is misleading in dysmetabolic syndrome and diabetes. So we use LDL particle number by NMR. That's our target and our goal, because it gets around the issue of the miscalculation that occurs when you have lots of small LDL and you have HDL deficiency and high triglycerides and all the things that screw up the Friedewald equation. But I think that you could use, I don't like the word moderate intensity or high intensity either, I would agree with that, but I think a coronary calcium score in this person is going to be very useful, because it'll tell you how aggressively you should lower the LDL.
I want to put a plug in there too. Many of the trials, when they looked at intensification of lipid-lowering therapy, did include fibrates before. As I mentioned before, the dyslipidemia of type 2 diabetes is not a cholesterol issue, it's a triglyceride issue. So I actually advocate for non-HDL cholesterol following, because if you use a fibrate, what you'll oftentimes do is remodel those triglyceride particles, so you'll lower the VLDL cholesterol and it'll end up in LDL. So if you can be mistakenly thinking that you're actually have not helped the patient when you use a fibrate. But what's happened is, you just, knowing the physiology, you need to have something that lowers the LDL at the same time. You will benefit them because the non-HDL cholesterol comes down. So I will follow both LDL and non-HDL cholesterol in these folks. The reason why I bring this up is because you can be misled with having a lower LDL than you and be led astray by that in patients with diabetes, because they have more VLDL cholesterol.
Yeah, we did a study where we looked at 7 million LDL particle number NMR spectra, and 1 million of those people had diabetes. And if you looked at those people, the LDL cholesterol was misleading in like 70% of them. It's just awful, which is one of the reasons why apolipoprotein B and LDL particle number by NMR are superior metrics for outcomes. And these were proven by looking at the MESA trial and other trials, where if you look prospectively, it's just a better marker. So I don't use the Friedewald equation anymore to guide me.
No, diabetic patients.
Will be as part of the lipid panel?
No. So it's a separate test. So the question is, these are separately indicated, separately measured things. Apolipoprotein B is an immunoassay, and it's trying to get at all the particles that contribute to atherosclerosis. And the NMR spectrum, similarly, it's a physicochemical test that doesn't use any equation. It just measures in nanomoles per liter the concentration of the particles circulating in the blood.
But the non-HDL cholesterol captures the cholesterol in all the ApoB particles. So, and the rule of thumb for non-HDL cholesterol is you want 30 points, within 30 points of the LDL. So if you have an LDL target less than 70, your non-HDL target should be less than 100.
Yeah, so modern, that would be a non-HDL below 85.
Yeah.
Okay. Next question. A 62-year-old woman with a history of hypertension, LDL cholesterol is 156. 10-year ASCVD risk is 10.4%. Reluctant to statin therapy. What do you recommend? Well, you guys should all get this right. Okay. I think they got a little influenced by Dr. Chaporia's lecture there.
Yeah, I think I can't speak for my colleagues up here, but I would agree with. I mean, look, the lady's hypertensive. Her LDL is pretty darn high. I mean, do I think she needs a statin? I actually do, and the equations change and you know are of changing veracity, I would say. But I do think a coronary calcium score. One of the benefits, and you heard about this earlier, actually. And that is that showing a person their calcium score. We participated in a study many years ago where we did carotid ultrasound, and if there was plaque, we made a refrigerator magnet with the picture of the plaque and gave it to the patient. And it turned out that doubled the likelihood that the person would listen to what you were saying, you know. And so the picture worth 1,000 words, I think, is legitimate. And if the coronary calcium score, certainly you can de-risk people at age 62. If the coronary calcium score is 0, then I think you could say, well, your cholesterol is high, but for whatever good reasons, you don't seem to have atherosclerosis of significance. But likelihood is this woman's going to have calcium score, and that may sway her to change her reluctance to statin therapy.
Yeah, and I will actually, if what you were saying is aligns with this, our EMR allows us to pull up the pictures of the CAC score.
And you show them.
And I show them to you. We just, you know, it's really, their eyes just widen. You just kind of go right down the heart, and you go, there should not be anything bright white here. It's in on the bone. And all of a sudden, this thing just explodes onto the screen. They go, they go, and then they do change. If her CAC score was 0, I would definitely do a carotid ultrasound. If she has any evidence of even mild plaque on the carotids, I would still.
Yeah, Matt Budoff, before you came, he talked about doing CT angiography in such people to pick up soft plaque that may not be manifest, but it certainly.
How often does that happen?
Actually, it's quite. Well, I don't know about age 62.
Yeah.
Younger than that, it's pretty common that you'll have
okay.
plaque forming, but it isn't yet calcified, right? 62 is long enough that you'd imagine that she would have calcification already. But yeah, I mean, ultrasonography is inexpensive, totally risk-free, and would be an additional piece of information that can be obtained. Matt also mentioned this, though, is that the IMT, so the carotid intermedial thickness is a surrogate really for stiff blood vessels, and it turns out it's once you factor in hypertension, you get rid of the IMT. So IMT is not a good measurement, but plaque is.
So you wouldn't reclassify the patient as low risk if the calcium score is 0. You would get either an high sensitivity CRP or calcium.
So I'd rephrase that a little bit. They would be low risk in the next 5 years of a cardiac event because a coronary calcium score of 0 in an appropriate age person prognoses a low risk of a cardiac event in the next 5 years. Now, she's 62, so the next 25 years, you're right, somebody who is hypertensive, I don't know about her other risk factors, but I wouldn't classify as low risk with this LDL and hypertension, yeah.
So let me ask you, would you repeat the calcium score if it's 0? And what time frame would you do that to make your next decision point?
5 years. So yeah, the answer is yes. Now, not if somebody, you know, they said, I'm 40 years old and I want to repeat, why'd you get one in the first place if you're 40 years old? But at 62, there is some evidence, and so the general number is 5 years. Yeah.
What about the different calculators for the ASCVD risk? What about the prevent score?
Yeah, none of the, and I'll ask them because these guys develop those scores. I'm more in the Budoff camp that I want to know if somebody has the disease. You know, if somebody comes in with a sore throat and they have a positive culture for strep, I don't care what their risk of having strep throat is. They have strep throat. So if somebody, I'm a cardiologist. Most of the people who come to me already have the disease, so I don't use those risk stratifiers. From a population perspective, it's useful, and earlier in life, because a lot of the things we used aren't very helpful at age 35, for example. So there, the risk stratifiers are good, but I'm going to turn to my left here for that.
I mean, what we've seen time and time again is whether it's the prevent score or some of these other scores, even getting more traditional with the Framingham risk score, right? They don't really do a lot to sway patient action, mainly because we're looking at 5-year, 10-year risk. of developing cardiovascular disease, whatever that time frame is. And for a lot of people, especially when they're younger, middle-aged adults, that does not register in the same way, of course, unless it's elevated risk, but that's going to be because of risk factors that have been identified. So I would take with a grain of salt in terms, like, as much as the risk scores are implemented, at the same time, in practice, it doesn't really hit. It's great for descriptive epidemiology, and sometimes it's used to help frame the identification of patients for clinical trials. And for those purposes, it has utility. But on a patient level, I would say it tends to be a little bit more limited. I do want to kind of do a slight pivot and just say, as I'm hearing a lot of these questions, even this question 15, the idea of doing a CAC score makes total sense. No need to do a CRP at this point. But the lack of inclusion of appreciating, at least in the background, thinking about prevention in terms of lifestyle. Of course, we always assume it to be assumed, but it's not always necessarily focused upon. And in this case of the 62-year-old woman, I'm looking at elevated LDL who doesn't want to go on to statins. Even if the CAC score is perfect, I don't see a good trajectory playing out in this case. And so whether you wait 5 years to reassess or not, you still have to intervene in some way here and not just assume that the watchful waiting approach with a zero CAC is going to necessarily be the solution.
We still have, yeah, I agree with you fully. She's still at high risk. Free will does play in the role in patient decision making. So I like the idea of, giving them time to, have a role in their decision making process, but then kind of put a hook into it by saying, if it does turn positive, you're on your way, we're going to recommend. I'd say in terms of the prevent risk calculator did change and lowered the overall risk compared. It's more accurate than the previous risk calculator, but then they just changed the range. That's high risk. So it turns out it's probably fairly similar. But what I tell my residents is, we use the risk calculator as a starting point, not an ending point. We use other things like Lp(a). We'll throw in a CAC score. We'll do family history is a big one for me. If they have a very strong family history of heart disease, I'll be much more likely to get off the fence in terms of non-invasive imaging studies or other things. So I only use it as a starting point. I don't say, oh, your risk is too low, or that sort of thing.
If you lower her age to 35.
Well, yeah, that was my point.
Yeah.
And that is, the risk calculators are very age dependent. So somebody can come with an LDL of 300, and if they're 20 years old, what's their risk of having an MI in the next 5 or 10 years? It's pretty close to zero if you're 20 years old, but that doesn't mean you're not going to embark on primary prevention therapy. The risk engines are good, and it boggles my mind. I have people sent to me, they've already had a coronary stent, and somebody says, well, their ASCV data, according to this, is they've already had disease, man. You don't need a risk stratifier for those people.
All right. I'll do the next question and then maybe skip a couple because I want to cover something else. 68-year-old male with a history of CAD, status post MI, 3 stents 3 years ago. LDL on 40 of rosuvastatin is 70. What would you add next? Okay. All right, that's great. So, Rich, what do you think?
I'm glad I don't sell fish oil to this audience, but yeah. I don't know which is better. I mean, what do I normally do? I had ezetimibe, I would agree with the group, but there are pretty convincing evidence that lower is better. You heard that already, and at least if you look at intracoronary ultrasound and all sorts of things, at least down to 20 milligrams per deciliter, there's a benefit. And ezetimibe is going to lower it 15%, right? So 15% of 70 is just over 10, which probably isn't going to get you to where you want to be. So I think you could make a compelling argument here for a PCSK9 inhibitor. And, later this year, the oral PCSK9 inhibitor will come out, and that may change this equation. But right now, I think either of those are legitimate. I would just discuss it with the patient.
Yeah.
Too quick. Oh, go ahead, Doc.
So fish oil, we don't know what the triglycerides are, so you don't necessarily want to use that in this situation. Niacin you definitely don't want to use because it wasn't shown to add to the rosuvastatin and it can increase the risk of diabetes. The difference between these two is going to be determined by insurance 99% of the time, in my experience. But exactly as you were saying, I mean, you can improve cardiovascular events with both ezetimibe and PCSK9 inhibitor addition. My preference would be the PCSK9 because you'll do a better job and it'll be better tolerated. And I mean, it'll be easier. I mean, it'll be easy, it's easy to use, it's well tolerated. But the insurance company is going to say Zetia. But then you just do that. They won't get down to less than 55, and then you can just go on to the PCSK9 and stop the Zetia.
Yeah, and you'll know that within a few weeks, actually. So you can give a 30-day prescription, recheck, and then if it isn't there, then switch.
Just this week, I had a patient come in who said that I was told not to take a statin because my HDL is very high.
Did you tell him to start smoking also? I mean,
You have some land in
yeah.
Florida to sell them?
a high HDL it isn't a condom, it doesn't protect you against disease. And first of all, when we did an analysis of the LDL particle number, because remember the Friedewald equation is messed up in terms of if you have HDLs that are high or low, the equation doesn't hold, just like we were talking about triglycerides a moment ago. So when we actually looked at the MESA data and you, or big databases, and you say, let's say somebody's LDL particle number is 800 nanomoles per liter. What's the sweet spot for HDL cholesterol? And it turns out high HDLs are harmful as prognosticators. They're not helpful. The sweet spot is between 45 and 50 milligrams per deciliter. And if you're people coming to me and say, I'm so proud I have an HDL of 100. Yeah, that means you have dysfunctional HDL particles. You shouldn't have an HDL cholesterol of 100. So it actually, if you're up at 100, you have twice the risk of a cardiovascular event compared to 45 or 50. So it's a total myth that high HDLs protect against cardiovascular events.
It is still true, though, if you have a low HDL at baseline, that is a predictor of future heart disease risk. But I agree with you, a high HDL nor an increase in HDL, that doesn't protect you either. So we just don't know, actually, we don't know what HDL does beneficially. We just know if it's low, then it's harmful.
There's a question over there.
What about those patients that have tried all of, I think, 4 of the statins, the injectable and Zetia, and can't tolerate it?
You have people who can't tolerate any drug? Amazing. Yeah, no, I mean, yes, there are such people. Well, we have a limited number of things, but obviously there are other things. And we have RNA therapeutics, right, inclisiran, which tells the liver to stop producing PCSK9. And it's almost as good as a PCSK9 inhibitor in terms of lowering LDL. It's not quite, but it's 90% as good, and it's every 6 months. So that's something that we give in our office all the time for the people who can't tolerate conventional drugs. But most of the time you can get by, whether it's nanodose statin, Repatha or Praluent, and as I said, soon more agents will be entering the market.
Yeah, you also have bempedoic acid, which can help you as well. We use bile acid resin binders for folks too. And then if worst case scenario, you can find a local, and they still have progressive heart disease, you can find a local apheresis unit, and they can come every 2 weeks and get apheresis. But it's difficult.
All right, we'll skip the next question because that pretty much covered it. Let's go to question 18, Benji. A 55-year-old man with type 2 diabetes, LDL of 157, triglycerides of 430, not on lipid therapy. Best initial therapy.
Mo, was that a fasting triglyceride, you know?
Good question. Let me think. What would be fool my audience here? Let's say fasting, for the sake of treatment. I don't know. Let's say 7.5. Okay.
So actually, let me ask my diabetologist here. So would that, if his hemoglobin A1C was 11 versus 6.5, how would that change your answer to this question?
I don't call myself a diabetologist, but I do go by endocrinologist. The reason why I say that is because we had a cardiometabolic clinic before Sergio Fazio came out and started our preventive cardiology clinic. We were run by a cardiologist and a diabetologist. And the patient with diabetes would go see the diabetologist, and the diabetologist would start them on insulin. Then they go across the door, Mayo Clinic model, and see the cardiologist. The cardiologist would put them on a high intensity statin. And so we would say that's not really optimal care for someone with diabetes in this situation, so I don't call myself. A diabetologist kind of sees things through one lens, just an editorial. But again, this is someone who probably has a genetic triglyceride disorder on top of their diabetes. If they had 11%, I would do, definitely start with treating the diabetes. I'm seeing an indication for a statin anyway, just give the high risk that they're going to need and probably will need lipid-lowering therapy because the evidence shows starting a statin in patients with diabetes would be beneficial. I have another answer for this person, though, because they're going to need more than a statin. Statins are lousy for triglyceride disorders to normalize their non-HDL cholesterol. So what would be what my colleagues here do to treat their triglyceride disorder?
All right, let's do the next question, and then I'll have you guys answer that. 3 months later, the LDL is 72 milligrams per deciliter, and the triglycerides are 310, just like you said, lousy for triglycerides. So triglycerides are on 310. What do you recommend? Okay.
Now, this is another educational opportunity for you here.
Go ahead, Rich.
I actually like high doses of omega-3 fatty acids in this particular arena because they are effective. One of the problems is it's a high pill burden, so you have to go sometimes to very high doses, right? And the dose that is approved for this particular drug would be 4,000 milligrams a day. I can tell you that years ago we did sequential experiments giving 4,000, 8,000, 12,000, 16,000, and it's dose dependent until you get steatorrhea from taking all the fish oil and you can't metabolize. So I think that's a reasonable choice, and there are outcomes data from this. I'm going to turn to my endocrinologist, previous diabetologist.
I chose. I chose D as the correct answer.
Yeah, and one of the questions is I'm going to ask him: is there any role for fibrates anymore?
Yes, I think there is, and because you have to use them understanding the biology behind them, including Vascepa. They both operate through the same way. They're PPAR alpha agonists. They both lower ApoC3. And so with a fibrate, and also with Vascepa, you can increase the LDL. You just have to pay attention to what's happening to the LDL and the non-HDL cholesterol when you start them. I was going to say that, either one of the top two could be perfectly fine. I like Vascepa as opposed to the over-the-counter where you're going up to 12 grams of fish oil a day, and then you do have a high burden. I think either one of those two would be fine. I would do something different, though. I'm assuming that this is a person who's got a BMI over 27.
Probably, yes.
Yeah. Well, in type 2 diabetes, I would treat him with a GLP-1. We have seen really remarkable responses when you can clear out the fat in the liver and with these meds to lowering triglyceride levels. And I believe type 2 diabetes with this lipid panel is the most difficult patient in our practice to treat. We have lots of them. We have many of them who've had a history of pancreatitis, and they say, well, I can't take a GLP-1. That's not true either. And we have seen people make really remarkable improvements by starting a GLP-1. So my point of talking about the GLP-1s in the diabetes talk was that cardiologists, who do lipid work too, need to start not thinking of GLP-1s as a diabetes drug. This is a cardiology drug. And that's
Yeah, we call it a cardiology drug that happens to lower blood sugar.
Exactly.
That's
Exactly.
what we call it.
So
What about a glitazone?
which one?
A glitazone.
So I'm not a big fan of that because you're basically potentially inducing an obese state to treat this situation. So in my lineup of drugs, pioglitazones, thiazide, like Actos or pioglitazone would be pretty much at the last one that I pull out of my back pocket for that process. And I would only use the lowest doses. I'd only use a 15, max of 30. You go up to 40, then you run into the problems with the fluid retention in the car and the heart failure risk. So, but you can use it. I have used it very rarely, but I would definitely. I think you have at least 3 good options, and I would start with a GLP-1.
All right, next question. 59-year-old female with type 2 diabetes. Forget about the head, full stop. Triglycerides 680. LDL is 92, HDL 38. Now, which is the best initial pharmacologic agent?
And an A1C.
No problem at all.
Make a note for next year.
You don't know it, but I had an ejector seat button up here.
He didn't like my answer.
No, for calling me a diabetologist.
Shift left.
Okay. I chose fibrate.
Well, Mr. Endocrinology, what would you say?
Well, I
So-
chose fibrate
Why? Yeah. Why?
because I wanted to reduce the risk of pancreatitis.
And that would be perfectly appropriate. And once your triglycerides are over 500, that's the indication for the fibrate. It is the easiest thing to do to bring the triglycerides down in that situation. So it is definitely an indication. The reality is you're going to start both at some point because you bring those triglycerides down. What you've done is you've remodeled, and LDL is now showing up. It's going to go up to 130. Easily. So you're going to need to have a statin eventually, whether you do them together or sequentially. I have no problem with either one of them. Vasipa will probably have some benefit, but it won't be, in my experience, as powerful as the fibrate, the 160 range. Niacin you definitely don't want to use.
Lipoprotein lipase, I mean, is this not high enough a triglyceride to use any of the newer drugs to lower triglycerides?
Well, the ANGPTL3s
Yeah.
inhibitors, no. Well, you can't get them indicated for this right now. So they're only for the homozygous FH, as far as I know, and people with familial chylomicronemia syndrome. So we're not going to be able to use those, the antisense ApoC3s yet, although that would be a really good option for this patient. We're really anxious for the non-familial chylomicronemia syndrome trials to come out for that, because that could be a real game changer for that. But I think fibrate would be a great choice to start, but you're going to need in 3 months to check them, 2 to 3 months, and probably start them on a statin anyway.
Okay, we have 1 minute and one question. 42-year-old man with a BMI of 35. 3 to 4 alcoholic drinks nightly. Triglycerides 900 milligrams per deciliter. You recommend? Trust me, it's difficult making up these questions, okay? I forget about hemoglobin A1C. Forget. All right. Well, I'll tell you what was behind my thinking here. Yes, weight loss, alcohol cessation is great, but how quickly will he really cut his alcohol back? Will he stop drinking? And he still has this risk of pancreatitis, and that's why I chose fibrate first, while we do everything else.
No, that's exactly right. I mean, I think the question is, A would be perfectly appropriate. I think, triglycerides typically have to be over 1,000 to really start to see the risk for pancreatitis come in, because you don't see it until it's over 2,000. But you get to 1,000, you saturate lipoprotein lipase, and then you start anything you put on top of that in terms of food with any fat content can jack you up to 3,000 quickly. So I think A would be perfectly appropriate, but it would depend on the patient. So, how much do you think that they could do that? I think covering them with a fibrate while you're waiting for the other things to kick in is perfectly appropriate, and then you can see how well they do in 6 months to a year. But here's again an opportunity for, we're completely ignoring the weight, which is, if you had an opportunity, if they could pay for it out of pocket, a GLP-1 would be a great medication for them to simultaneously start with that, because it has been shown to reduce alcohol use disorders in terms of helping. So it's like one of those things you can say, look, you've been thinking about stopping drinking. We're going to give you a medication that you can set a firm date on this. And this can, it's been shown to help out. We don't have the randomized controlled trials yet, but just anecdotally, if you've been using these things, people, people come back and just say, this doesn't appeal to me as much. And again, you'd want to use it anyway with a BMI 35 and this triglyceride disorder, because you could really do, and it won't likely with the previous patient or this patient prevent them from needing a lipid-lowering drug, but you'll be able to get by with less, because they won't have the same visceral adiposity pressure driving their liver fat, driving their triglyceride production, and insulin resistance that clears at issues. So I think you have an opportunity to start to think beyond the usual things and start to incorporate the GLP-1s.
I know that fibrates are like contraindicated when patients have liver disease, and a lot of the times, right, like when we see patients with like AUD, especially severe AUD, they tend to have active liver disease. Are you able to speak a bit on that?
I'm not aware that it's contraindicated in liver disease. I know for kidney disease, there's a dose adjustment for that, but I'm not aware of that for liver disease. Usually in end-stage liver disease, you're not seeing this so much because your liver's not making it as much. But yeah, no, I'd have to go back and look. I'd have to check on that.
All right, thank you all very much. We do have an after-conference get-together with some hors d'oeuvres and stuff like that. I appreciate all of you being here and your patience, and thank you for all the panel for all your input. Thank you to the AV guys, Benji, Tim, and
Tell them to fill out their form.
great conference.